So these are certain questions which will be confusing for the clinician, that whether, supposing my patient is doing well on ACE inhibitor, should I switch to ARNI or should I wait till the patient becomes unstable? There is basically an illusion about stability of heart failure. The illusion is that 20% of the stable patients, no prior heart failure hospitalization, the paradigm heart failure had a primary event. Secondly, in spite of treatment, 17% of the patients died during the course of trial. Of stable patients who experienced a primary event, death preceded heart failure hospitalization 51%, and 60% of the deaths were sudden. So this enlightens us with the facts that the illusion that our patients are stable with heart failure is not so. These patients are not stable because today this patient which is stable can go into an unstable phase and complications can arise. We know ARNI is a drug which has got a lot of benefit, so the take-home message should be ARNI should be started as early as possible and do not wait till the patient starts deteriorating. Now let us see what is the current 2022 guidelines of ACEI, ACC, or the Heart Failure Society of America tries to suggest. It has clearly suggested that in patients with heart failure with reduced ejection fraction, those who are in class 2 to 3 symptoms, use of ARNI is recommended as a class 1A indication to prevent or reduce mortality and morbidity. Now the question comes, how do we differentiate between acute decompensated heart failure from de novo heart failure? How do these two subsets differ? It is very important as you see this comparative chart. Acute decompensated heart failure versus de novo heart failure, there are 5 points on which we can differentiate it. First are the patient characteristics. If you see the ADHF patients or the acute decompensated heart failure patients, they are usually older patients, the worse baseline status and laboratory findings, and they usually have a known history of underlying heart disease. But de novo heart failure patients do not have any history of heart failure and they suddenly come in. Now if you see the comorbidities, the second aspect is that these patients of ADHF have IHD, COPD, atrial fibrillation, diabetes, stroke or TIA, history of CABG and PCI. These are more frequent, but these are less frequent in de novo heart failure. Now there are certain triggering events in acute decompensated heart failure, and these are mostly the poor compliance or the resistance to take medications. Infections do, especially viral infection, do precipitate heart failure. The diet, excessive sodium intake, cardiovascular complication and interventional surgery, drugs like alcohol or digitalis can also trigger events, but in de novo heart failure, it is predominantly the cardiac ischemia or valvular incompetence that occurs because of an acute MI or a mitral regurgitation or an inflammatory problem like viral myocarditis or toxic, like which can be drug induced, like using anti-cancer drugs, can immediately lead to de novo heart failure. Now clinical presentation of ADHF is they have dyspnea, orthopnea, edema, ascites and weight gain. This is the standard type of patients that we see in our day-to-day practice. But what happens in a de novo heart failure patient is that they present with cardiogenic shock or acute pulmonary edema as a first presentation. Lastly, the pathophysiology involved in ADHF is that there is a pulmonary and systemic vascular congestion caused by LV dysfunction, maladaptive neurohumoral activation, fluid overload and redistribution. So this is a very chronic process in the ADHF group. But in de novo, these events are acute, but there is a hemodynamic derangement and also there is gradually increasing LV systolic dysfunction.